Hello to everyone. My name is María-Victoria Mateos. I work as a hematologist and director of the myeloma unit at the University Hospital of Salamanca in Spain. And I am going to try to address today the question if is it possible to utilize different BCMA-targeted therapy sequentially. And in order to answer this question, during the International Myeloma Society meeting in LA in August 2022, an abstract was presented basically based on the use of BCMA CAR-T cilta-cel in a cohort of patients previously exposed to BCMA-targeted therapy, either antibody-drug conjugated, belantamab mafodotin, or BCMA bispecific monoclonal antibodies. The primary endpoint of this cohort of patients treated with cilta-cel was to evaluate the minimal residual disease negativity rate with sensitivity level of the 10 to the -5. And I have to say that 20 patients were included in this cohort. 13 patients had been previously exposed to belantamab mafodotin. And it's important to see how 4 out of these 13 patients were treated with belantamab as part of the last line of therapy, and majority of the patients were refractory to belantamab mafodotin. When we evaluate the patients previously exposed with bispecific monoclonal antibodies, 7 patients had been previously treated with bispecific antibodies, and only 2 patients the bispecific was taking part of their last line of therapy, and 72% of the patients were refractory to the bispecific. In terms of efficacy, I would say that cilta-cel was effective basically in this population of patients previously exposed to belantamab mafodotin, and the overall response rate was 62, as well as in patients previously exposed to bispecific monoclonal antibodies, and the overall response rate was 57%. Approximately 1/3 of patients previously treated with belamab achieved complete response, and 14% of the patients treated with bispecifics achieved complete response with cilta-cel. The median durability of the response, or the median progression-free survival, was slightly longer for those patients treated with cilta-cel after belantamab mafodotin, 9.5 months, and 5.3 months for patients previously exposed to bispecific monoclonal antibodies. From my point of view, these data are quite preliminary because the sample size is rather small, but we get some relevant information about the factors that can potentially predict responses to cilta-cel when they had been previously exposed to either belantamab or bispecific monoclonal antibodies. And in both situations, the shorter median treatment duration of their last prior anti-BCMA therapy, as well as the longer median time between the last anti-BCMA targeted therapy and the apheresis and the cilta-cel administration, resulted in a higher probability of having an optimal response for cilta-cel. So I think that this information is relevant from the efficacy point of view, and especially for the future sequencing approaches. From the safety point of view, to say that no new safety signal was reported, and cilta-cel resulted in cytokine release syndrome in majority of the patients, less patients with ICANS, and the hematological toxicity we usually see with the cilta-cel in other cohorts of patients. So I would say that the answer to the question if it is possible to plan a different BCMA-targeted therapy in a sequential way, I would say that the answer is yes. It's true that the efficacy data here reported are a bit less effective in comparison with the results reported in the CARTITUDE-1 in patients naive for BCMA-targeted therapy. But I think that the work is being done, and definitely the sample size of this cohort of patients is rather small, and definitely I think that we have to continue investigating in what is the optimal sequencing for BCMA-targeted therapy.